Good evening, everyone. I'm David Karp, Chief of Rheumatology at the University of Texas Southwestern Medical Center in Dallas and President of the ACR. I would like to welcome you to the ACR Town Hall on building vaccine confidence in rheumatic disease patients. Tonight, we will discuss important issues surrounding COVID-19 vaccine hesitancy and give you support on how to talk to your patients. This is just one part of the ACR's response to COVID-19 that has included our practice advice for providers, our guidance for the care of both adult and pediatric patients with rheumatic disease during the COVID-19 pandemic, and of course, our recently updated guidance for the use of COVID-19 vaccines in patients with rheumatic and autoimmune diseases. And with the recent authorization of the Pfizer vaccine for children 12 to 15, I'm sure we will see another update addressing vaccination in pediatric rheumatology patients soon. Earlier this week, the Rheumatology Research Foundation held a webinar for patients and families to answer questions about COVID-19 and vaccines. First, I have some housekeeping issues. As the evening progresses, you can ask your questions using the Q&A feature at the bottom of your screen, not the chat, the Q&A. They will be monitored and selected ones answered during the discussion. Also, this session will be recorded, and if you know someone who would like to watch it later, it will be on the ACR website by the end of the day tomorrow. I'm pleased to be joined tonight by Dr. Irene Blanco and Dr. Chris Phillips. Irene is professor at the Albert Einstein College of Medicine and is their Associate Dean for the Office of Diversity Affairs. Dr. Blanco is one of the co-chairs of the ACR Diversity, Equity, and Inclusion Subcommittee and is a member of our Committee on Training and Workforce. Dr. Phillips is the founder of Paducah Rheumatology in Kentucky. He was a member of our COVID-19 Practice and Advocacy Task Force and is the chair of our Insurance Subcommittee. And now, it is my honor to introduce our guest speaker tonight, Dr. Kimberly Manning. Dr. Manning is known as a rock star in medical education circles. Her lectures on the lessons patients can teach us are not only educational and applicable to all physicians, but entertaining, passionate, and resonate emotionally. I have assigned them to my students and fellows, telling them they can't call themselves a doctor unless they watch a Dr. Manning lecture. Every time I see a tweet from her about a Grady elder, I stop whatever I'm doing and read another amazing story full of empathy and humanity. Dr. Manning is a professor at Emory University in Atlanta and Associate Vice Chair for Diversity, Equity, and Inclusion in the Department of Medicine. She is a graduate of Meharry Medical College and did her residency in medicine and pediatrics at Metro Health in Cleveland, Ohio, which is incidentally where I got my start in rheumatology as a high school and college student working in a lab during the summer. Dr. Manning is the recipient of many awards, including the ACGME Parker Palmer Courage to Teach Award and the 2019 Lifetime Achievement Award by the Association of Black Women Physicians. And her blog was voted one of the top 4 medical blogs by Oprah Winfrey's O Magazine. We are lucky to have Dr. Manning here tonight to speak about the background to vaccine hesitancy and then discuss some of the scenarios based on the questions you have submitted ahead of time. Dr. Manning, welcome.
As spoiler alert, I'm not a rheumatologist, but as a general internist, I certainly interface closely with patients who see rheumatologists, but also patients in general who have lots of concerns and many things that fold into the big decision about whether or not they'll agree to be vaccinated or not. I have no financial disclosures. And I just want to start by setting the stage. Early in 2020, or rather early in 2019, we had never even heard of SARS-CoV-2. It's amazing what a difference a year or two makes and how so much is now consumed with thinking about COVID-19. Looking at the numbers and how it's played out in the United States with more than 500,000 deaths, it's really dizzying and is part of the reason why we're talking so much about trying to prevent more people from getting this. Every time we turn around, we hear this word, unprecedented. I had to look to see what Webster's dictionary had to say about this. And it's described as something that's never happened or existed in the past. So much of the aftermath and what we've experienced with COVID-19 is unprecedented in our lifetimes. And so there's some aspects, though, that make us want to get vaccinated. This image of me and my mom in spring of 2020 is pretty much the way I saw my mother for an entire year. She lives right here in Atlanta with me. And this image alone both makes me happy and a little sad and glad that my mom has since been vaccinated. We hear about the health disparities, which were thrown into relief by COVID-19. I won't go into them too much, but just as a quick example, which is quite similar in your states, is that in Georgia, the COVID-19 hospitalizations disproportionately impacted people of color, specifically Black Americans, and also those of lower resources. And so lots of the things that we've seen with the social determinants of health and health disparities were really amplified by COVID-19. I just want to draw your attention to this occupational risk score chart. Looks pretty busy, but if you zoom in on it, just know that each of these circles represents your risk and also a type of job. So the larger the circle, the bigger your risk. And as you look at these images here, think about who are doing these jobs: janitors, retail salespersons, personal aides, nurses. And so we have to, whenever we talk about people's process of making a decision to be vaccinated or not, we must consider who those individuals are. And if we think about who's working in these jobs, we understand why the disparities have been at play. And I think one of the elephants in the room is this collision now between what we often refer to as the two pandemics, that of the unprecedented COVID-19 with anti-Black racism or social injustice, which is a precedented pandemic. So what is different now, and it's important for us to consider this as we're talking to our patients and what's swirling around them in their day-to-day worlds, is that this chronic pandemic of social injustice is now something that everybody is looking at. We have cell phones to capture things. We can see things on our Twitter feeds and on our social media feeds nonstop. There's so many things reminding us. And all of this, for the first time, this old pandemic is now happening at the same time as this new pandemic of COVID-19. And so this is impacting our patients and what they're thinking about. So I'd like for you to all reflect with me on this question. I admit, if you notice so far, I've not used the term vaccine hesitancy, and that's for a reason. I'm not a fan of the term vaccine hesitancy. Hesitancy, as defined by Webster's dictionary, is a quality or a state of being hesitant, indecision, reluctance. It's often something that conveys fear or trepidation, and not really power, right? But what if we looked at the word deliberation? Deliberation gives you more power. It's the act of thinking about or discussing something and deciding carefully, the act of deliberating. And so, quite frankly, when I'm talking about any patient who has not yet decided to be vaccinated or who has decided to be vaccinated, I often refer to the process as a process of deliberation. Because for any big decision that any of us make in our lives, there will be a process of deliberation. And what makes something a big decision for you could be different for somebody else depending upon their lived experience. This is my family back in the day standing in front of a home that we had just bought. Now, I'll tell you, when we bought this house, we lived in a house that probably cost a third of what this house cost. This was in a better neighborhood. It had very good schools. It was walking distance to Emory School of Medicine. It was a really great opportunity, but it was going to be a big change to our family. It was going to be expensive. We had small kids. We didn't know what to expect. And it was a really big decision. My husband came and saw the house. He's a person who does real estate investing. He looks at houses all the time. And he said, this is a good deal. And he was ready to sign on the dotted line right then and there. But see, me, I'm not a real estate investor. I don't really know much about, what, dental molding is, or I didn't know much about the difference between a house built in 1929 and 2009. I didn't know. But our process of deliberation was a little different because of who we were. So it took a lot of time for me to think that through. I went home, I thought about it, I thought about the cost, and ultimately we made a decision to move into the home that we still live in and will probably grow old in. But it was not a snap decision. Now, just to keep this light for y'all, this is me standing in front of my Honda Odyssey that I really wanted this minivan. I thought that I wanted a minivan. I had kids that played sports and kids that needed to go to, school and carpool and all these things. I wanted those sliding doors and all that, but I was still kind of cool at this point. I still went to brunch with my friends, did cool things. And I tried to picture this minivan pulling up in the valet and me getting into it. So, when I went to go look at the minivan, the person at the Honda dealership, they said a lot of good things about the car. They showed me every feature. The sliding doors are automatic. It had a moonroof. It had a really good policy on it and warranty on it. But while I was standing in the dealership, I did not say yes on the spot. I needed to think about it because I wasn't really sure. It was going to be a big decision for me. And ultimately, after much thinking, talking to my husband, thinking about what's important to me and my family, I made a decision to get a minivan. I became a minivan mom. And it was one of the best decisions of my life. I could fit as many kids in this car and had as many cup holders as anybody could have. This was me pretty much for about 10 years straight. And just this year, I turned 50 and decided it was time to let go of the minivan. And that was a big decision too, to let go of my beloved swagger wagon, y'all. But it was a big decision because of who I am. So what really impacts a big decision? And I tell you this because for some people, getting a vaccine for COVID-19 is a big decision. A lot of the people that you'll be caring for, they're not doctors. They may not have somebody who's in their family who's in medicine. They're not seeing patients in the hospital who are needing to be intubated or who have long hauler syndrome. Maybe they're not. But what impacts a big decision? Well, who you are. So who you are. This is me in college in my dorm room at Tuskegee University, young and free and happy. I'm not so sure I would have been worried about becoming deathly ill at that time. I try to imagine, 19-year-old me trying to make a decision about whether or not to be vaccinated for COVID. I try to imagine 19-year-old me having all the access to social media that people have, or being at a historically Black institution, Tuskegee to be specific. All the things that I might have been hearing around that time then. And I try to imagine me making a decision. What you value, what matters to you the most? What is the sacrifice or the cost to make this decision? Maybe it's a house where you're going to have to save more money and budget much tighter. Maybe the sacrifice is that historically you come from a marginalized group that have historically had issues with people treating you unkindly. Science is real, but history is real too. And that could be something that's factoring into the things you think. What's the perceived threat? Certainly history plays a part in this, but for some people, especially your patients, what if your concern is, I already have a revved up immune system. All the problems I have are because of my immune system. You mean to tell me you want to give me something to ignite it? I don't think so. Is there an unmet need? I mean, do I need this? Do I feel like, what if I don't ever go anywhere? What if I'm somebody who just doesn't necessarily feel like I'm at risk? Maybe I'm like this girl dancing in the dorm room with the Prince poster and the Marilyn Monroe poster on the wall. Maybe I just don't think I need it. Autonomy. I want to be able to make this decision for me. I don't want to do it just because you said so. I need to decide for myself in the time frame that works for me. And then who is asking? Are you somebody with your back turned, typing on a computer while you're asking me? Were you short with me? Did you mispronounce my name? Did you use the wrong pronoun even though I told you my pronoun? Who is asking, and what kind of therapeutic alliance have you worked at to make sure that I feel like I want to say yes to you? And then how you are being asked. That's a really important thing too, because for some folks, it may take a little bit more time for them to decide, and some of it is just how they're being asked. So I want to point out also the significance of social injustice and vaccine deliberation, and recognizing that for many of our patients, what they see for some people is not the same as what they see for people who look exactly like them. And so if you are this person and you imagine, right, that maybe, just maybe, someone doesn't have my best interest in mind. Just maybe someone would do me harm. There are people who think that, and we have to own the fact that there are probably some reasons people think that. And as we get ready to have these conversations with our patients and tackle them in their process of deliberation, considering these factors that they see every single day on TV and that we see too is really important. And so every day when I'm at Grady Hospital, but also when I'm walking around Atlanta, going places, I talk to people and ask them how they feel about being vaccinated for COVID. Now, I admit, as a physician, I'm in this setting where I'm constantly around people who've been vaccinated, right? But then I step outside of my bubble into the Black community, into, retail places and folks just all around the city. And I ask that question, and I have to say, we still have a long way to go. We have a lot of people who still have questions. So most recently, I was talking to a woman by the name of Mary. She works in one of our local pharmacies. And I was talking to her, name changed, and said, Mary, did you already get your vaccine? And Mary told me, no, I didn't get a vaccine. And I said, oh, wow, okay. Is there anything I can tell you about it? And she said, I'm really somebody who's scared of needles. And at first I was going to get the one-shot vaccine, and then all that stuff came out about it. So Mary and I stood and talked in CVS Pharmacy for a while about the Johnson & Johnson vaccine, what it meant to her, and whether or not, and I gave her some factual information to help her in her deliberation process. Did Mary on the spot say, where can I go get my vaccine tomorrow? No. But the seed was planted. We kept the dialogue open. And I go in that pharmacy all the time. I'll see her again. Just the other day, I was at one of my favorite stores and saw a woman that I see all the time there named Jaquan, name changed. And Jaquan is actually someone who is living with a rheumatologic disease and told me, no, I'm not being vaccinated because, one, I don't even think it's going to work for me. And I don't necessarily want to put something into my body that, is not going to work in the first place. And we started talking a little bit more, and she had some very valid, good questions. And she had a rheumatologist. I asked if she talked to her rheumatologist about it. And she said, my rheumatologist kind of acted like I was tripping for not wanting to be vaccinated and kind of seemed like a little bit like they were talking down to me. So I stopped talking about it. I ain't taking that vaccine. Provided a little more factual information and hope that planted a seed in Jaquan as well. Anthony is one of our Grady employees that I was talking to one day, and I asked Anthony if he would be vaccinated. And he said to me, I have never seen anything in the United States that is really good that's offered to Black people and poor people at the same time as everybody else. I'm not doing it. And I said, wow, okay. And we started to talk about it, and we just kind of went back and forth and talked and talked and talked. And Anthony was still a vehement no. But I provided some factual information, ran into him a few more times in the hospital. Then about 2 weeks ago, I saw Anthony told me, I've been vaccinated. I thought a lot about what you said, and I had to think about it. And I think that's important, recognizing that, sometimes we feel this urgency to close the deal with our patients, but our patients are people. And I think it really starts with understanding this question, what's your why? Every person is not a monolith. Certainly every minority is not a monolith, but also every one of your patients who says no, who has a rheumatologic disease, it may be for reasons that we have no idea about until we ask. So I just want to close with this. And I want us to think about, as we approach our patients who are still deliberating, ask first, why? Why do you, or why did you get vaccinated, or why do you not wish to be vaccinated? When they answer, listen completely. One of my patients called me out once and said, sometimes you do that thing doctors do where they ask you a question and the whole time you're talking, they plotting what they want to say next. So I've learned from that to just sit still and listen to what the patient is saying. And then think about who's asking me this? Outside of being my patient, when you are not here with me, what is your life like? Are you in an over-policed neighborhood? Are you resource poor? Are you going through some things and seeing some things in your day-to-day life that are traumatic, might make you not have trust? Are you from Tuskegee? I mean, what is going on with you? No question is stupid. If your patient is concerned that they are microchipped, ask them, what do they mean by that? Let's talk about what you think that could mean. And really, hold back on passing any judgment on patients, because remember, it's particularly when there is not racial concordance, or if you're dealing with certain individuals where you don't always have cultural concordance, or there could be some areas where there's not trust. that judgment could really close the door, and you want to keep the dialogue going by continuing to probe. Okay, so hypothetically speaking, if there was a chip in you, it was a chip in this, let's think about how that would get inside of you. Well, the needles we use are really small. They're super tiny. It goes into your muscle, not a blood vessel. Let's talk about how you would be chipped. But also acknowledge the slow yes. That's one of my favorite and most encouraging things, is that there is a such thing as a slow yes. Because remember, depending upon who you are, your deliberation process could require a little bit more and a little bit more and a little bit more. So just keep planting that seed. Recognize that just like that car dealer at the Honda that day that wanted to sell me that Odyssey, he didn't sell it to me on a Tuesday. He didn't sell it to me until about 2 weeks later, because I needed to think about it. And yes, there is urgency when it comes to being vaccinated for COVID. But if you don't keep the door open, and if you don't work at trying to plant the seed and keep that trust open, we're definitely not going to get there. And so if you don't remember anything I said, other than having a few pretty pictures for you to look at and a Prince poster on my wall in college, I want you to remember this. What's your why? Every patient is an individual who deserves your full respect enough to ask, why do you feel the way you do? Why are you concerned about this thing? And then give them an answer that meets them in a space of respect. Our patients can fully understand science. It's okay to explain how an mRNA vaccine works. Explain what happened with the Johnson & Johnson vaccine and where we are now. Explain the numbers. A lot of our patients want to know that and walk away feeling more confident after they've heard that. Thank you very much.
Thank you very much, Dr. Manning. I'd like to turn it over now to Dr. Blanco and Dr. Phillips to ask some questions that we've thought of before based on some scenarios that people sent us ahead of time.
Dr. Manning, thank you so much for your talk. I think it's highlighted so many things that we've been thinking about in the discussions that we've been having for our patients. And I love your hashtag, what's your why? Because I think that's just so important in everything that we really think about. It's particularly for our patients that have such complicated diseases and complicated treatment regimens. I think we have hard conversations with them already, right? How do we keep those conversations going? And so I'm just going to present a couple of scenarios that our participants have been hearing with their patients, and we're hoping to sort of brainstorm how to approach these discussions with their patients.
Awesome.
So the first one that we have is, the meds for our diseases take so long to come out. They've been just tested in thousands of patients. These vaccines have barely been tested and were just rushed out to the market. How do I know if they're safe? What's going to happen in 10 years?
Well, I love that question. That's one that is not limited to the rheumatologist, that's for sure. We get that a lot. And, I usually start with acknowledging that's a good question. That's a very valid concern. I can see how you'd say that. So I think, again, starting with an acknowledgement, particularly if you truly agree, and I do agree with that. So let's talk a little bit about what happens next, though, in terms of vaccine development. And so, I can see how it's seen that way, but then providing that contextual information about how, this is not the first coronavirus that we ever saw. There were people already working, scientists working on trying to develop a vaccine already. And so I like to think of it this way. I say to people, it's kind of like, what if you're at home and somebody busts in the front door and says, we need a cake, a birthday cake, hurry up. And I'll open my cabinet and I have everything in the house to make the cake. I already had everything because I knew that I was probably going to need to make a cake, and I was thinking about making the cake already. And I was already getting everything ready. So I didn't have to go and buy flour, buy an egg, buy these things, right? I had everything there and already started that process. And so all I needed to do was really pop it in the oven. So it seems like it was quick, but maybe it wasn't. And then the other thing is, depending upon who my patient is, when I'm thinking about my patients who have racial concordance with me, my Black American patients, I often talk to them about the things that I know for sure, like who was working on the vaccines, who were the scientists involved. I let them know about Dr. Kizzy Corbett, who was a key member there. And also I tell them that I was enrolled in the trial and am still enrolled in the trial. And so they know a Black person who was enrolled in the trial. Hello, her. Before it got EUA, before we knew what was happening. And I think that having those conversations and really addressing the concern, because once I'll say a few things and I'll pause and say, am I answering this right? Or is it something else you want to know? Because sometimes they want to know something different. So I think that's a place where I begin.
Wonderful. I mean, I think, it's been a discussion, I think, for some of our patients, particularly. So I'm in New York, right? So we have a very international population, just like Atlanta, right? We have to remind people that, SARS and MERS were coronaviruses, are coronaviruses. I'm like, do you remember that pandemic a few years ago, SARS, that really hit Asia and the Middle East really badly? Like, yeah, I'm like, that was a coronavirus. People were working on this because they wanted to prevent that happening again. So we had a head start. We were very, very lucky. It was just hidden in a lab somewhere, but people were ready to go, right? So Kizzy Corbett was, had her data, had her mRNA.
I didn't mention this, but I should have mentioned also that no steps were skipped in the process studying the vaccines. I think that's something that's resonated with a lot of our patients, explaining that, there was still phase 1, 2, and 3. I let them know what kind of trial I was in, what it was like for me, how I got consented. And a really important thing to share with some of our patients who may be worried about something negative is that the big difference between now and what happened in Macon County, Alabama with the untreated syphilis study is that those folks were being studied and then the gold standard came out and nobody told them. So I got a shot that I didn't know if it was a placebo or a vaccine or not, but then the gold standard got emergency use authorization. So they unblinded me. And I found out that I had gotten placebo. So instead of letting me walk around thinking I got vaccinated, I got a vaccine. And that has meant a lot also to our patients, letting us know that, hey, things are a little bit different now. It is a much more diverse group of people sitting at the table and, and speaking up.
Sure. Chris, David, do you want to jump in?
Yeah, I would agree with you guys. My experience has basically been with, emphasizing to the patients that there have not been any steps skipped, but rather the typical administrative red tape processes have been removed. The fact that the government funded some of these companies to pre-produce their vaccine, which they would not have otherwise done. So there's plenty of rational reasons that we've been able to get these vaccines to market as quickly as we have, and still have done the studies in as robust of a manner as have been in the past.
Yeah, I would echo what Dr. Manning has said about how the vaccines have been in production or development for decades. Probably the first live group of vaccine hesitant people that I talked to were the nurses in our arthritis clinic. And the nurse manager had asked me to come by and talk to them because they were sort of like, no, it's going to make me sterile. Why should I want to put something in my body? I'll just keep wearing the mask. And so I was asked to talk to them. And I said, look, as Dr. Blanco put forward, we had SARS and MERS, and these vaccines were developed for that. And unfortunately, those diseases went away. So, but we had the technology, and it was just ready to go, waiting for an mRNA sequence. And this is the most fantastic vaccine platform you can ever imagine, because you don't have to grow influenza in chicken eggs. You don't have to, create a recombinant protein. You just have to make a new synthetic RNA sequence. And when you have a variant, you have a new sequence, and your platform is ready to go. Now, it's not that simple to manufacture all of that, but conceptually, it's a lot simpler than other kinds of vaccines. And it was just ready and waiting for us to, unfortunately, have a pandemic with a new microorganism that needed this platform.
you know, you touched on this in your presentation, and I think, you know, it behooves us to really talk about it now. And the next scenario that I'd like to bring forth is, you know, Doc, medicine has been tried and developed, and all sorts of medicines and treatments have been tried on Black and brown patients. Many times, a lot of times, it's been done in a way to exploit my community. I can't be another guinea pig to the experiment. You know, rheumatology, like many of the medicine specialties, is not very diverse. And like many medical fields, I think we have a hard time having those hard conversations, especially around race, when providers are not racially concordant with their patients. So for our listeners, how can we start to engage our patients?
Well, I mean, I think you know already from Twitter that I'm an optimist and I'm a prisoner of hope. So I think that people respond to empathy. I have seen patients absolutely love their doctor who doesn't have English as a first language, who came to the US for residency and had not met too many people that looked like them beforehand. People respond to that. So I think number one are first thinking about the things that are fully in our control. The things that are fully in our control are things like our body language, how we listen, the things we learned as medical students, but I think we forget when we get really busy. So for me, just one very practical thing that I do is I try to be psychomotor retarded. I do not do a lot of fast moving when somebody's talking to me about something that concerns them. I even think about the intonation of my voice when I'm responding to their questions to make sure that they know I'm listening and that I respect them. And I even use their name when I start having a conversation. So if I was speaking to Mary, I might say, you know, and Mary has let me know to call her Mary. That's her preferred thing to be called. I say, Mary, you know what? That's real talk. Because I approach patients as myself. I don't really code switch. And you know, that's real talk. A lot of stuff has happened. You know, things like you know, what happened in Macon County, Alabama, studies after that, what happened to, you know, people who were enslaved and brought here against their will. It's a lot of awful stuff that has happened, and that's real, and I can't deny that. I want to talk to you, though, a little bit about where we are right now. I disclosed to them that I was in a study. That has resonated a lot with many of my patients. That's one piece, but also I might say specifically, let's talk about what your concern is. So is your concern that if we vaccinate you, that we are injecting you with something that could do you harm, and then we are following you to see what happens? Is that what your concern is? Tell me the concern. Because I think that's where the what's your why comes in, because it's sort of this sort of generic thing. And when I start to probe patients, I think sometimes they realize they don't really think that. So probing a little bit further, but making sure you let people know that you care. Bad stuff did happen. Stuff happened after Macon County, Alabama. If you notice, as a Tuskegee graduate, I don't refer to it as the Tuskegee study, because Tuskegee to me is my alma mater. It is not a place where atrocious things happen. So I make sure, though, that I find out specifically. I try to drill down on what the actual concern is. And then I tell them a little bit about how the studies work, what they're doing now, and how, to some degree, anything that we take ever, we all are a little bit a part of a study, right? Because we are going to, you know, report if we have some side effect. Someone will ask us questions, and that's what we do for each other out of love. So just like I signed up to spend several hours being involved in a study, I did that for you, for us, so that we could find out more information, and so that you knew somebody who looked like you was in these studies. So I think one of the easiest things people can do who do not have racial concordance with their patient is, if the patient says bad things happen to my people, co-sign it. You know, because it did. It did. They may have read medical apartheid. They may know all the things that happened way after. Acknowledge it. And then you can move on and start to have a real conversation. I think it goes wrong when people brush over that because it's so uncomfortable. You know, but it's true. And we can't confront anything or deal with it until we just walk through it.
Great. Thank you so much. Chris, anything's popping up in the Q&A that we want to?
Sure. Yeah, I'm just looking over the Q&A as a reminder to the participants. If you've got questions, go ahead and pop them in there, and we'll try to pick out the good ones to discuss. So here's one for Dr. Manning, and I think you've touched a bit on this already. How would you approach patients who have been burned by clinicians in the past? Maybe the beginning of the relationship's rocky. How do you kind of overcome that, or kind of get back to that position of trust to be able to talk to them about this?
I think this is what I tell the medical students all the time. I tell them patients are people. And the same thing you do with somebody else that you started off lumpy with or that you offended is what you do with your patients. If I'm the patient I told you that said that I was doing that thing where you plan what you're going to say, even though there was a lady who needed an echocardiogram, but she'd already had one. And she was telling me that she had one, but I was already planning why she needed the echo. And when they got ready to do it, she refused it. And she said, you didn't listen to me. And she was kind of mad with me. So I said I was sorry. And I promised that I would do better. And I told her that she was right and I was wrong. And, just like, when my son did something the other day and I snapped at him and I was rude to him and I hurt his feelings, I went to my son and I said, I shouldn't have snapped at you. I was wrong. And then I showed him through my actions that I wanted to listen to him and show and validate him and see him. So I think those things, are very simple. It's the same thing we do with anybody that we care about. And the cool thing about rheumatologists is that you all develop such strong alliances with your patients because the treatment regimens are so, it makes them so vulnerable in many ways, right? They have side effects, they can cause you to gain weight, all of these things, right? So I think it's really important to just take a moment to see where your patient is, and if you're wrong and if you were rude, autocorrect, say you're sorry.
So we have, and in listening to you, one of the scenarios we came up and you addressed it a little bit in your talk, but patients, there's a lot of things out in the media, and we hear, right? It's a way to control us by the government. There's a chip, etc. I love your recommendations for staying open. But for those of us that can't keep the poker face, right? Where like I have no chill, right? You're gonna see it in my face, and I'm just, I'm like, So how as we providers, how can we kind of keep that neutrality when we hear something that's really just not factual or based maybe so much in reality? We know that it could be based in fears, it could be based in misinformation. So we don't really want to discount that, and we don't want to offend our patients, but at the same time, it's just, you hear something just so kind of shocking that you didn't expect. Sort of, how can we maybe not?
How do you keep your
How do you keep a poker face?
I mean, I think about the long game. The long game is that I want to protect you, and I do not want to have to walk over to a COVID ward and to sit with your family and talk about you being taken off of a ventilator. So when I think about that, I'm like, if I have to listen to you talk to me about a microchip, I can do that. So oftentimes, what I'll ask somebody is, where did you hear that from? Where did you get that from? And they say, oh, I saw it on my Facebook feed. I said, oh, word, show me on your Facebook feed. I want to see. And I'll look with them and be like, oh, okay, yeah. So one of the common ones I get is the one that this is going to cause you to be infertile. And unfortunately, there's sometimes people in the healthcare community who are some of the people saying these things, which is very confusing to our patients. And many of them look like me. And so I would be like, show me. I'll look at the video and I say, okay, so let's talk about this. And I will go science. I will talk science. And even when the microchip one with my patients, you know, the reason why I can keep my face straight is because if you really believe it, if you really believe that, then I need to entertain it, because it's going to create a barrier to me for being able to protect you with this vaccine. And so I'll say, you know, honestly, you know, let's just play out if the government was going to track you with this. You know, honestly, it would be a waste of money because you got a smartphone. If they want to find you, they can just track you with a smartphone. They probably would, you know, spend their time doing something else. I mean, real talk. But let's talk about trackers and tracers. And I'll tell them about tagged RBC scans and things that we use as tracers, and how they don't linger in the body and how they go away, and what's in the vaccines, how the mRNA vaccines are not stable when they get to body temperature and how they just go away. That's why we have to keep them so cold. And I think that when we start really respecting our patients with the science, you'd be surprised at how many people will respond and say, oh, wow, okay, that makes sense. So I say, show me, where did you hear that? Let me see.
Dr. Manning, I'm seeing a couple of questions I can kind of loop into one here, and maybe Dr. Karp and Blanco, you guys can jump in on this as well. So what about providers who maybe are hesitant to recommend the vaccine to certain patients, and or staff or nurses in our clinic who maybe have chosen not to take the vaccine, and how we handle that with them, or how we message that with our patients?
Ooh, that is so hard. I mean, well, I will say, and Dr. Karp, y'all jump in too if you have things to say. You're a whole president of the ACR. I mean, come on. But you know, the folks we work with together in our clinical environments, we develop relationships with them. We love them. So on one end, I straight up have an agenda when it comes to the staff that work with me. I come in every day and I am trying to plant as many seeds as I can. And I keep them in my head. There is a slow yes. And I've seen a lot of slow yeses. And I encourage you all to track your slow yeses so that you'll be encouraged and not give up. But that being said, you know, our medical recommendation is that our patients be vaccinated. And if you have somebody that's coming in the way of your patient and telling them otherwise, you could at least, you know, I've told staff before that, listen, if you ain't feeling the vaccine, I do not want you to be going to our patients telling them not to be vaccinated. We can sort of talk that thing through. But I think leveraging our relationships with staff, I think, is very, very important. And for a lot of us, there is racial concordance with the people who are saying no. So that's probably even trickier for you all in rheumatology. But I think, you know, as we have relationships, keep it real. Like, listen, you can't be checking the patient out and checking the blood pressure, and on the side, you know, telling them don't get vaccinated. I mean, we got to work together in this and find a happy medium. So I think that's a conversation that we can have and that I've had, and it actually is okay.
So, you know, I think just to sort of add on to what you've said about the slow yes, is that I find that, you know, I might not be the best person to try and persuade people. So in one of our clinics, again, most of the nurses had serious concerns based on lies, you know, falsehoods that they had seen on the internet primarily. And, you know, when I would suggest that they take the vaccine, you know, the nurses were like, well, no. But then one of my younger female physicians, who's very, very persistent, would talk to them every week and say, you know, this is the answer. This is the science. You know, what do you think you're going to do? Well, maybe I'll think about it. And after a couple of weeks, then, you know, the next thing I know, you know, there they are, you know, showing their vaccine cards. And she was able to get them to get vaccinated as a group. And again, it was the slow yes. They just needed to think about it more, and they needed to have somebody just bug them a little bit every single week to get them to think more about it.
How powerful, though, would it be for, you know, my senior white male rheumatologist to look at me, a Black patient, and hear, you know what, I'm a doctor. I have privilege. There's a lot of things about my life that have made it such that, you know, I'm maybe not worried about some of the stuff that you're worried about. You know, nobody watched my folk from 1940s to the 1970s to see what would happen. You know, I get it, but I've been taking care of you now for 10 years. And, you know, we have been through a lot. We've been through steroids. We've been through, you know, all the mAbs, you know, we've been through a lot together. And, you know, I'm just letting you know that I get it, the differences between us in making this decision, but I really think this is I'm here to answer any questions that you have. And I think that, you know, because we also have to think about, you know, the minority tax and all of these things. Like, you know, we can't deploy everybody with racial concordance to do this. And I do think that some folks have way more power than they realize. And I'm certainly not saying that you don't go hard at this, Dr. Karp or any others, but definitely recognize that who you are and acknowledging who you are and how easy it was for you to make a decision, and then just calling that thing out, that can mean a lot to your patient and have people really feel seen.
So on that thread, and so we'll stay with Dr. Karp, some of the things that we've been hearing from our patients, right, is the worry about flare. You know, this, and you know, Dr. Manny, you talked about it in your presentation, right? So, you know, my immune system is already crazy. It's already activated. You're supposed to give me this vaccine, and everybody talks about how, you know, if I get fevers or joint pains, it's working. I don't want fevers and joint pains. That's my disease. So how do we sort of reassure them and toe that fine line with our patients in this setting?
Well, you know, I think it's maybe this is the time when you need to you know put on the doctor hat and be very you know, scientific about it. You know, what we have a lot of people who've gotten vaccines. A lot of patients with lupus and rheumatoid arthritis have already been vaccinated with this vaccine, as well as many other vaccines. You know, every year we have our patients get influenza vaccines. We give them Pneumovax or now, you know, our other pneumonia vaccines, the Shingrix vaccine. You know, so we do that because we know that our patients will have a bad outcome if they get an infectious disease. And so we have a lot of experience with that. And in truth, not all patients flare. A few do. And it's so few that it's almost, you wonder, you know, even if it's coincidental, you know, you see the internet is full, or not, or even the published literature, the scientific literature has letters to the editor that say somebody with rheumatoid arthritis was well controlled for years, and then, you know, 10 days after they got their COVID-19 vaccine, they had a flare in their knee. And so, is that due to the vaccine, or is that just, you know, coincidental? And so I tell patients that you know, we can treat your flares. We know how to do that. And if you have a flare, we will take care of you. But in the meantime, now you're protected from a disease that's deadly. And, you know, the worst thing that could happen is that you get COVID-19, because that is most likely going to cause your immune system to go crazy and could make your disease much worse, and make it so worse that I can't control it afterwards. So I don't want you to get COVID-19. I don't want you to be a recluse in your house and not be able to go out and be with your friends and your relatives. And we just have to look at our experience thus far, that there have been, you know, thousands of patients with rheumatic and autoimmune diseases who have gotten these vaccines and have done well. Chris, I don't know if you have any thoughts about that.
Yeah, you know, I would agree. I think some patients may respond to statistics and some may not. But I think that it's one of the most important things is just to emphasize how deadly this disease can be, especially to our patients. You know, I've occasionally used statistics like the idea that the risk of anaphylaxis is 10 per million, give or take. The risk of thrombosis from the J&J is somewhere maybe in that same magnitude. And the risk of mortality from COVID is 10 to 20,000 per million, you know, depending upon what statistic you use. And sometimes I think patients, you know, and this goes with our drugs as well, they see that it may cause cancer, TB, whatever on the commercial, and they misvalue how likely those things are to happen. And so trying to kind of recenter that is sometimes helpful.
this would be a great place where an infographic would be great. This is your risk of flare. This is your risk of COVID-19. Because unfortunately, despite what seems to be happening in America, we can look around the world and we know that COVID-19 is not going away, and there's still going to be a risk for people who are not vaccinated.
Mm-hmm. Definitely. Chris, any in the Q&A?
Yeah, I think we can kind of dovetail off of that last conversation. I'm seeing several things popping up about the lack of data, right? So how do we speak to our patients when we don't have data about vaccine efficacy in immune-compromised patients, and or the fact that the studies may not have included as many of our patients as we'd like? How do we have those conversations with our patients? So I guess that any of us could try to answer that, I suppose. Dr. Karp, maybe you want to start?
Well, the vaccine efficacy question comes up all the time, and this is really where you need to bring shared decision making to the forefront. And I think there are data coming out that show from our patients, as well as the solid organ transplant literature and other diseases. There's data coming out that people who are on strong immunosuppression make a less robust antibody response, but we really don't know what what level of antibody is going to be protective, is going to be good enough. So even if you're on a methotrexate, for example, and you make a tenfold reduced antibody response to an individual who's not on anything, that still may be good enough. Plus, what we're not measuring when we look at these antibody responses are T lymphocyte responses. And there's again a paper that I just learned about from Twitter last night, but it was published in Annals of Rheumatic Disease. It was a research letter that, again, showed somebody who was on rituximab, or a series of patients on rituximab who made virtually no antibody response, yet they had fairly robust T-cell responses to SARS-CoV-2 peptides. And some of our pathologists here at UT Southwestern have showed me similar data from our transplant patients, where they made no antibody responses but had very strong T-cell responses. So I don't know. I agree with the questioners that we are somewhat in a data-free zone, and within 3 to 6 months we will have a lot more data on that. But in the meantime, it's again, I tell patients a little bit of protection is better than none. And even if it prevents you from getting a serious case of COVID-19 that lands you in the hospital, or worse yet, in the ICU, that's better than that's a better outcome. So I try and promote that even on people, even if people are on immunosuppression. Again, I ask people to look to our guidance that's on the website that gives some ideas for what you can do with medications. It's not always easy, and usually my patients ask me about it after they've been vaccinated. Dr. Karp, should I have held my medicine when I took the vaccine? And it's like, if you'd asked me ahead of time, I would have said, you're doing great, stop it for a week afterwards, or whatever the situation would be. But that's life. I just congratulate them on getting vaccinated, because it was the best decision they could make.
I'll jump in and add also that, millions of people have been vaccinated now. We have V-Safe, which is our tracker for, side effects and after vaccination health, that's through the CDC. And so when you're talking about millions of people who've been vaccinated, then that's a lot of opportunities for things to be reported and for us to learn more. So I often tell people also that we're looking to just see what information we get. This is all new. Remember in 2019, we didn't even hardly know anything about COVID-19. So we're trying to catch up right along with everybody else. And as an internist, one of the things I do is try for folks who are on some type of immune suppression, I try to leverage that to get them to try to convince other people in their family and in their community to be vaccinated, because, you know, you really do want your herd around you to be vaccinated if you're somebody, you know, who's taking some type of B-cell modulator. So that's another thing that from the general internal medicine side that we do.
You know, it's the what's your why, right? Like, let it be me. I think the last scenario that I'll present tonight, and sorry, my children keep opening and closing the door I hear in the background. So that we have some patients, you know, I haven't gotten COVID yet. Why bother?
I haven't gotten it, or I have gotten it?
I haven't gotten it.
Okay.
They're like, I dodged the bullet. So why? Let everybody else get vaccinated.
Yeah. So yeah, that might be one of the ones where, when you were talking about the poker face, that I would have to work on my poker face for, because, you know, some people have never wrecked their car, but then they do. So a lot of things could happen next. But my angle for that is again still science. I talk about the new variants that we have, and how many of them are far more contagious than the earlier ones. So maybe you didn't get COVID in the first round back in the spring of 2020, but one of these newer variants, it takes a little less for you to get it. So that's one thing I talk about. And then, you know, depending upon what your lived experience is like, some people are not afraid to die, but they are afraid of being disabled. So I often talk a lot about the disability, and not even just the severe disability. I talk about things like, you know, I know people who've gotten COVID and it's 8 months later and they still can't smell or taste, and or coffee tastes like motor oil. I have had so many people be like to that. The long haulers syndrome, the cloudy thinking. One lady I was caring for was a chef, and she still could not taste or smell. So it was like it destroyed her livelihood. She couldn't do her job. So some of these things that seem really subtle, it's that kind of motivational interviewing techniques, right? Where you're always trying to figure out what matters the most to the patient. And once you kind of find out what that is, start talking to them about it. So you telling me that you didn't get, and I will probably keep it real. So you telling me you didn't get COVID yet, why bother? Is like me telling you that I didn't, you know, I didn't die in a car crash, so I never, because I had my seatbelt off. You know, I mean, it could still happen, and the chance of it happening is so significant. And if it's preventable, like, why are we doing that? So, and then I just keep probing some more. I think the other one too we hear a lot is people saying they got COVID already, and that they don't need to be vaccinated because they already had COVID. And again, I'm just like a metaphor person. And I always tell people that, like, you know, some people get COVID and they make a bunch of antibodies and they are protected. But we don't know how long those antibodies last. And there are some people who get COVID and they didn't make any antibodies. So it's like when my kids wash dishes, sometimes the dishes are squeaky clean. Sometimes they are not clean at all. The vaccine is like putting them in the very best high-powered dishwasher where you get a predictable response every time. So go on and put your immune system in the dishwasher and get it clean.
I'm totally stealing that analogy. It's wonderful. All right. I think
Okay.
maybe a time. Yeah.
Right. Well, I actually did want to maybe address very quickly the last question I see, because we had talked about it earlier. You never know when you're going to be giving a talk when something is going to come up that very day. And of course, the CDC has announced that those of us who are fully vaccinated no longer need to wear masks. And they sort of skirted. They didn't come clean on what people with autoimmune diseases or immunocompromised patients should do. And I'll say again, this is an area where we have no data. What am I going to advise my patients? I'm going to say that I think that they should continue to wear masks, particularly if they do not know the vaccine status of the people around them. It's one thing to know that your family members have all been vaccinated, and certainly that's not a risky thing. But if you're going to go to a new situation, go to work perhaps where you don't know whether your coworkers have been vaccinated, I would suggest to them that they still be cautious until we have more data. I think that's the prudent thing to do. Well, I think that ends our program tonight. And as I mentioned, this town hall will be available on the rheumatology.org website by the end of the day tomorrow. You know, the ACR's promise is to be there for you so that you can be there for your patients. And I want to thank you all and have a good night.